This conference will now be recorded.
Okay, greetings everybody. My name is Peter Kafka. This is our second advanced recurrent AnCan prostate cancer meeting of the month of December 2023. And I'll be moderating tonight. I want to quick word to our sponsors, which are Bayer, Pfizer, Sumitovant, which bought out Myovant, um, which is Sumitomo Pharmaceuticals, um, Blue Earth, Myriad, Telix, Johnson and Johnson, which Janssen, they used the Janssen name for many years, but now they're going back to the Johnson and Johnson name. So at this point, those, and we want to thank them for their participation over the year, several years now, and we're grateful for their contribution. And as I mentioned last meeting, we are not beholden to them. We're not endorsing their products or drugs or scans or whatever. But we certainly appreciate their recognition of the value of support groups, peer support groups. So we don't give medical advice, although there are a couple of physicians and medical professionals on our calls often, as tonight. But we give peer counseling. We kind of say what we would do in that kind of situation, not telling anybody what to do or giving particular medical advice. So, Jeff Marchi, do you have anything tonight? Welcome.
No, thank you, Peter.
Okay, I was expecting one new person. I got a heads up, and they might join us. If that's the case, maybe we'll make room. I don't know whether he called you Rick or not. His name is Mike Morris from Indianapolis. I think he's a personal friend of Dr. Carlos Huerta. So Carlos gave me a heads up that they'd probably be on tonight, but right now, no. Bob McHugh, do you have anything tonight?
No, thank you.
Okay. Well, with that said, the recording's on. So go ahead, Rick, with your announcements and comments.
Yeah, just bear with me 1 second. I just have to send a quick note to the organizers here. Actually, Peter's remarks about the sponsors is very apt. As you know, we don't ask for money very often. And the reason we can do that is because we have excellent support from our sponsors, and we're small. We're relative to some of the other organizations, we're very, very small. We have 4 contract people and nobody full time that takes pay. And compare that to, say, 0 with somewhere between 60 and 70 people on staff. So we don't need to raise anywhere near as much money. And that means we don't have to come to you because we ask the sponsors to give us funds because we consider this to be a benefit, and the pharmaceutical companies want to be associated with it. So we really do bring it to you from them. That said, we are all volunteers, or most of us are volunteers. We've got over 100. I should say we've got somewhere between 80 and 100 volunteers right now. And and it's very important that people value volunteer time. And we're not, we want people to think about what it means when they call us up or when we spend time like we do right now, um, every week trying to support everybody. And I think we do a pretty good job. And I would say we do um, the best job that is done anywhere. So when it comes to support groups, certainly for prostate cancer and even for some of our other groups. So with that said, you all should have received our annual fundraising letter, and there's a number of people on here who are great sponsors, great contributors, I should say, donors for us, and we thank you very much. But for those who haven't donated um, yet, or maybe made a small donation, we just want you to consider us in your end of year giving plans. Not everybody can afford to give, we get it. But if you can, that would be great. And if you can't afford to give, but you'd like to figure out how to donate some time to us, I'm sure there's stuff that we can find for you to do. Because the more that we get from, the more time we get from volunteers, the less we have to pay. And we've got too many projects. Right now, for example, we've got a significant issue with our website. It's affected a couple of people I see on this call. We're trying to correct it. Probably means we're going to have to switch webmasters very shortly. The site's being reloaded as we speak. Earlier on today, Jimmy called me because he couldn't see the donate button because it had dropped the image. And this is all part of this issue we're trying to resolve right now. So if any of you have tried to donate in the past couple of days and haven't found the image, go back and look. We reloaded it, but it could drop again. But we're on top of it. We've just got to find somebody. So that's all I want to say. Just think about us kindly. And I may say this again at the end if there are any new people that come in, and we'll be reminding you through the month of February. We have a very, very generous donor who has agreed to match donations up to a certain maximum. So that doubles your donation right now. And I also want to say a big thank you to David Muslin, who has chaired this subcommittee, this fundraising subcommittee that we're working on right now. And some of you may even get to speak to David in person. So that's it. That's what I wanted to say. Thank you for listening.
Okay. Thank you. You know, I think it's a human quirk or trait that we often have to be reminded of things. I mean, and there's no shame in that. I mean, um, just just like many of us have brain fog trying to remember names. I mean, I spaced out a couple of names this week, and I felt really bad because I should have known the person. They were staring me right in the face. Don't you recognize me? But and the same thing with sometimes giving. I mean, so uh, we need to be reminded sometimes, quite often actually. Um, that's why bills come to us so often and reminder notices that it's time to pay our insurance and this and that. But even more so with charitable things, which aren't bills, but we just need to be on top of it. So there's no problem reminding us. Well, thank you, Rick, for doing that and putting that together, and David Muslim and anybody else who was on board with that one. Good job. Okay, we don't have a lot of people that want to speak tonight, so we might have some good space in between, maybe some great conversation. We'll see. Um, a few people joined late. Tell me, Herb, Jimmy, Russ, Jim Jeffries, do any of you have anything you want to bring up tonight?
Just a quick update from me.
It's Herb? Okay.
Yeah.
Okay, gotcha. Okay, we'll squeeze you in for sure.
I'm okay, Pete. Thank
Okay,
you.
okay, let's start going with Mark. Mark Valens. You said you've already talked to Rick on something, but you want to bring us up to date on it?
No, it was our conversation we had last week with Rick. Um, and so the local doctor had prescribed um, Casodex and Lupron. Then I had my call with Dr. Borno at UCSF a couple days after that, and she said, yes, use the Casodex until I start the Lupron, and I started the Lupron on Wednesday, and then continue taking the Casodex until I start Xtandi, and I've got it. That's coming by mail order. It hasn't showed up yet, but so she and Rick I brought up Orgovyx and darolutamide, and I don't quite understand why, but she wanted me to keep doing the Casodex and the Lupron. Um, and then the next day, I had a conversation with Mac Roach about uh, doing radiation, and he thinks it's important that I get it as soon as I can. So at his suggestion, I've started the process for getting it done at UCSF and the local radiation people up here in Medford, in Oregon. And whichever one can take me the first is going to get me. And that's all I got for now.
So I'll clarify a couple of things. Well, I think what we said to you was um, that, first of all, with respect to the Casodex and the Lupron, that's the old way to do it. The new way to do it is with Orgovyx. The bottom line is it should be the same, but it won't be as good for you, the patient, because the Orgovyx is a more effective drug. It starts quicker and it lets go quicker. And that's really important. So whilst Dr. Borno said, no, it's not a problem, stick with it, it's because they're essentially equivalent, but they're just not as good. You don't need the Casodex if you take the Orgovyx. You do if you take the Lupron. And the Orgovyx is just easier. But can't argue with that. Although if I were advocating for myself, I would say, well, I really prefer the Orgovyx, Dr. Borno, because we've seen people's testosterone return much quicker afterwards. So I've got to leave that one with you. And we did discuss, I think we discussed that last week. The other thing we said is Casodex, your local person was offering you Casodex and Lupron. You didn't mention Xtandi last week, enzalutamide. The fact that they're adding is what we told you to talk about. But the best drug for them to add, if they could, is darolutamide, because you're going to feel a lot better on the darolutamide than the enzalutamide, the Xtandi. So again, our suggestion of using Orgovyx and Xtandi is basically in your interest, because your quality of life is going to be better with Orgovyx and Xtandi than it would be with Casodex, Lupron, and, excuse me, let me start over again. We suggested Orgovyx and darolutamide, Nubeqa, and your quality of life is going to be much better with Orgovyx and darolutamide, Nubeqa, than it is with Casodex, Lupron, and enzalutamide Xtandi. So we can only leave it with you. Again, this is why we say you are your best advocate. And
Well,
you
Rick,
have
I
to go
tried
back
to make that argument after listening to you people, but I followed Dr. Borno's advice, and she heard me, and she wanted it to stay with the Casodex and the Lupron, so I didn't fight her.
Okay. Well, there are guys on this call that can tell you the benefits. And, if you don't If you don't feel great, then you got to go back and say, Dr. Borno, this is why I asked for this, that, or the other. But that's why we suggest it. The net effect, hopefully, in controlling your disease will be very, very similar. But the effect on you may not be so similar.
Well, I had Lupron and Xtandi before, and Dr. Borno's point was you tolerated that all right, so we know there's not going to be surprises with that.
Okay, that's fine. Yeah.
Okay.
Okay, thanks.
Yeah, I mean, Dr. Borno has a pretty sterling reputation. Yeah, I wonder if the doctors don't have personal experience with these drugs. I mean, they know what they do, and they're certainly experts in the pharmaceutical sense. But the feedback from patients is a really important factor, and I don't know how much of that filters down to all the doctors, our personal experience. If enough people let them know that they have far better quality of life with one drug than another, it it starts getting louder in their ears. But what do I know? I have no idea. She might have her own reasons for doing this, and maybe because you tolerated it before, might have something to do with it. I don't know. But you can always change when you're not. Although Lupron does take a while to get out of your system, but you can always change.
Yeah, we're just doing the 1 month Lupron in case we want to change.
Oh, you're only going to do 1 month shots. Okay, good. Okay, that's smart. And you know the drill with Xtandi, because that can be a little bit of a wild ride. So
yeah.
Okay.
Okay, thanks guys. That's all.
Okay, Mark. Good luck with this. And I wasn't quite clear on the Mac Roach and the local radiation in Oregon. Which are you doing? Radiation at UCSF, or are you going to do radiation in Oregon?
Max thinks I should get it as soon as I can, and both places are kind of backed up. So Max suggested I started the process in both places, and we'll see who can do me first.
Interesting. Okay. Interesting approach. Good. Anybody else have any comment for Mark? Thoughts, experience?
My experience with Xtandi and Nubeqa, I was on Xtandi. I had severe dizziness. And when I spoke to my doctor, I explained that, and I said, I want to try Nubeqa. It's like 100-degree turn as far as my dizziness goes. So if you're experiencing dizziness, consider it. But you're going to find out whatever side effects you're going to have, and then bring it up to discussion or whatever that appeals to you. But that's my experience.
Very good.
I
Good comment.
can only add my experience again. I've been on Xtandi and had severe fatigue, and I'm on Nubeqa or darolutamide now and have zero fatigue. But again, it's just one individual, so take it for what it's worth.
Okay. Well, yeah, these are important comments and experiences. And again, I don't, make sure our doctors are aware of our experience. Just let them know what our quality of life is, because they're the ones prescribing. Okay.
So, Peter, let me just say quickly, for Mark's benefit. My bad. I didn't read all your history, and I had forgotten that you tolerated Lupron and enzalutamide fairly well. But what we try and do in this forum is to give you best practices. And we know that Orgovyx and darolutamide, if you can get it, are best practices. Unfortunately, Orgovyx and darolutamide may require more work on the part of the practitioner. Often
She did
do.
bring that up. She said it would
Right.
take a lot longer to get it.
Well, it wouldn't take a lot longer. It would take more effort on her part. She wasn't exactly. I mean, look, we like Dr. Borno. She's a good doc, but she's only there part-time, and she wants to get her job done. And if she can give you Lupron, and if you get Casodex, Lupron, and enzalutamide, bish, bash, bosh, we're all done. But if you went back and said, Dr. Haller, don't you think that the quality of life for Mark might possibly be better? She'd have to say yes. Now, we can take the simple way, and you tolerated it well, and that's fantastic. But we've got men on this site who don't tolerate those drugs as well. And so we'll always say to you, do the best you can to get what is state of the art. And Orgovyx is state of the art. It's a pill. And darolutamide is state of the art. It came in several years after the enzalutamide. And we'll keep pushing for that. And if the gents don't want or are happy with what they've got, God bless you. But we just want to tell you what the best is out there based on what we hear from other peers. As Peter said, very, very appropriately, we don't give medical advice. We're all peers, but we tell you what our experiences are. Right, Mr. Kafka?
Right. And another thing which I did is call Bayer up directly and ask him what's involved in getting it. Sometimes they'll ship you a couple of months of darolutamide for free just to get you rolling on it, because they know that there's some bugaboos in getting it to people and getting it prescribed. So Bayer is actually pretty proactive in helping us get on these drugs. You can call their patient assistance program, and they're pretty darn good with that. They provided it for me for free for 3 years. Never even went through my insurance. Okay, Thomas, can you hear us?
Yeah, let me turn my mic on. I hear you fine.
Okay. So Thomas, just for a so you went by Fred before, but now you're Thomas. Is that correct?
That's right. Yeah, normally I would use, I mean, for, a long time in my life, I've always used my legal name Fred on most of my medical, legal, those kinds of things, so that there are, so it's clear who I am when I have to deal with those people. But my life, my personal life, I've many years ago, I started using my middle name, which is Thomas, and I just prefer that now. And I used Fred, I think, on the forum here because I didn't feel comfortable. I didn't know what I was getting myself into, and now I'm starting to feel more comfortable about what's going on and how people have communicated with me. I'm starting to feel a little bit closer to the other men who are on this forum, and so I just would prefer to use Thomas because of that.
Okay, you got it. We'll use Thomas.
Okie
So
dokie.
tell us your last name again.
Matika, Matica, Matika.
Okay. Okay, so what's up?
Well, I had been under treatment at a local clinic here, and the advice that I've gotten from on the forum is that I'm not getting good treatment, and that I should go someplace else. Well, anyway, the bottom line here is that I had been even at that time I had been registered at OHSU, and I had my urologist send a referral to OHSU. So they have that now, and I'm in the queue over there to go over and see the oncologists over there. I yet have to have, I called today again, and indeed I am in the queue, and they're gathering information or doing their whatever they have to do, and they're going to call me back, and then I will tell them, who I want to go see, and I've got a couple of the doctors picked out that were mentioned, and I've looked at their bios, and their bios do look good, and like they are really involved in this, in the prostate oncology, prostate cancer oncology. So I'm going to go over there and see what happens. And I have tomorrow I have my third Firmagon treatment, and I'm going to go do that, see what my doctor says, and at the same time, I'm going to go over, technically I'm going for a second opinion, but I'm probably going to switch over to OHSU. It's kind of a hassle getting over there for me, but I'm going to do it. And the guys kind of were, pretty, I don't know how to say it, pretty clear that would be something that I should investigate. So I'm going to do it, and I'm on my way there.
Where do you live? In Eastern Oregon?
I live in Vancouver, Washington,
Oh,
just north,
okay.
just north of Portland.
On the border. Okay.
Yeah,
Good.
yeah.
Okay.
And the only problems I'm having now, I had a really nice
How do you let
outbreak.
that?
I had a really nice outbreak of shingles, and that's I'm dealing with that now. And so I'm taking some gabapentin for that, and some acetaminophen and that sort of thing. But it's pretty debilitating. I mean, I had a very large outbreak, and it's very painful. And but I'm dealing with that, and I think it's slowly getting better. But it's not something that just heals up overnight. It takes quite a while for the nerves to settle down. So that's my only real health issue at this time. I feel very positive. I feel very positive. I'm planning. I want to go out and do some backpacking and things like that. I mean, so I've got my mind set on that, and I'm just trying to take care of myself day to day.
Have you ever had the Shingrix vaccine for shingles?
No, I'm aware of that. But
yeah, you might want to think about it. I've done it because shingles can come back on you. And now that you know how uncomfortable it is, just be alert, because sometimes we get some of us are more vulnerable than others.
This is in this case, this is coming back. Many, back when I was probably around 20 years old, I had a small shingles outbreak on my back, very small but very painful, about the size of a quarter, but it was really painful, and it has come back, and I'm not sure why. I'm not sure if it's because of the cancer, but if the cancer has affected my immune system much, maybe that's what brought the shingles back.
Interesting. Okay. Before I open it up to everybody else, I got to ask you another question while we're talking about discomfort. 3 Firmagon shots. I mean, Firmagon shots are not the most comfortable thing in the world either. I mean, I understand one. I mean, I remember having one to start the ball rolling years ago for myself. But and Len has the world record for Firmagon shots. It's a pretty uncomfortable thing to have that shot in the belly there. But you seem to be doing okay with it, and you don't mind it?
No, it doesn't bother me a bit. I know. I remember somebody saying on the forum here that they couldn't stand that shot in their belly, and I thought, well, I'll give it a try, and the first one, First one is a double shot, and they give you 2 injections. Second one was a single. The single one kind of, it was swollen and a little bit sore and inflamed, but in several days that went away. But I mean, it didn't cause me any more discomfort than any other kind of vaccine or anything like that. Yeah. So that doesn't bother me at all.
Interesting. Okay. Anybody else have a comment for Thomas, or do you have any specific questions you want to, that you want to bring up tonight to the group or concerns?
I don't think no, I don't think I have anything yet. I'm just kind of settling down into my current treatment, and I'm just kind of wondering, what I'm going to do. I mean, should I go on doing both treatments? I mean, I know that sounds absurd, but I was just thinking about it. So, I mean, eventually, I'm going to have to say to oncologist number one that I'm going someplace else. And is it just that simple? I mean, I want to keep going along with his treatment, which doesn't seem to be, very I don't know. I'm not sure what, but regardless, I'll go along with him for a while, and eventually I'm going to have to say, okay, I'm going someplace else for a second opinion, and then when I go over there, I might see that these people are really more qualified, to give me guidance in this situation, and I'm going to stop going to see him, so I'm going to have to tell him that, So if anybody can say or comment about how to do that, or if it's not a big deal, maybe I'd like to hear something about that.
Okay.
Well,
Anybody have a comment about that?
I switched oncologists, and it's as simple as saying, it's been nice working with you, but I'm going elsewhere. Because remember, you are the boss. You're in charge of your treatment. And so if you determine that second oncologist is better, it's real simple. You just say goodbye, and it's been nice working with you, and that's the end of it.
Yeah, when my urologist, when I asked for this this referral, my oncologist referred me to radiation oncology to a specific doctor. And I told the person on the phone, I said, no, I don't want that. I want to choose my doctor, and I've got somebody in mind. And so I want to make sure that there's nothing on my paperwork that says I'm going to a specific doctor. Today I double checked that, and they said that was the case. I'm not referred to any specific doctor now. So I understand. I understand about the. Go ahead.
Let me explain the politics in this. It'll help you understand it and everybody understand it better.
Okay.
Urologists are trained as surgeons, and the surgery part of prostate cancer technically finishes once they've done the surgery. However, prostate cancer can recur, and in most diseases, when the surgical part is done, the surgeons bow out and the oncologist comes into play. However, with urology, now I'll back up. In some specialties, the surgeons are trained in internal medicine and follow-up, like a GYN oncologist is trained in both surgery and some medical oncology, but then they do have GYN medical oncologists too, but there is training in their residency, so they can follow up. That is not the case for urologists. So the urologists have to learn how to treat advanced prostate cancer, and in many instances, I don't mean to brag, but we literally know more about treating advanced prostate cancer than the urologists do. However, it's very profitable, especially giving shots. And whether you give them once a month, once every 3 months, what have you, it's a cash cow. And every time you get one, ka-ching, 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 and the urologists don't want to give up patients. So they find every excuse under the sun not to give you up. If they send you to a radiation oncologist, he'll do the radiation oncology and you'll come back to the urologist. We know from being in this biz for a long time, I'm watching Herb Courtney there shaking his head all the time and agreeing with me. We know that the genitourinary medical oncologists know this space the best. A lot of medical oncologists don't know the space because it's moving so quickly, and most urologists don't know the space. There are probably a handful, half a dozen, who think they do. Of those half a dozen, I would say maybe half of them do, and we've already seen the other half don't. We had one, we hosted one not so long ago, and for me personally, no names, it was a bit of an embarrassment, truly. But I was convinced because two of my board members said, "Give it a try, give it a try." But it wasn't good. So you are perfectly entitled to go to your urologist and say, Doctor Uro, I now have recurrent prostate cancer. This isn't your field. I want to go to somebody who specializes in this. I'm curious if there's anybody on the call right now who dumped to not their medical oncologist, because I know that Herb had to switch medical oncologist, but is there anybody who dumped a urologist to go to a GU med onc?
Yeah, I originally dumped the urologist before I went to the first oncologist, and then dumped the first oncologist to go to the one you guys recommended that turned out to be phenomenal.
Okay. Anyone else? Anyone else have any?
Yeah, I immediately, as soon as my biopsy was done, I went to a medical oncologist. I knew that urologists were this was beyond them.
Jimmy?
I unfortunately idealized my urologist, not knowing, ignorantly, being unaware that a medical oncologist was the doctor of choice who I should have gone with. Even he tried to put me onto one up at Sloan Kettering because of his name, Scardino. I stayed with him and assumed he would be my guide, my quarterback. He'd be the person who would know enough of medical oncology and whatever else, radiology, to guide me in the direction of what was my next move. I did the same thing with another well-known urologist, both who I think know more than most average urologists. You know who I'm talking about, California guy, New York guy. But eventually I started becoming aware of the fact that I had to stick with the medical oncologist and radiation oncologist because that's where I was. And I do realize the difference now, and I'm happy to be in the camp of the medical oncologist, radiologist, rather than my urologist. Although I would like to touch base once in a while with them just to thank them for their guidance.
Alan, what was your experience?
Yeah, so now you all got me worried. I mean, I have a medical oncologist, Gaines Min, and I see him every 6 months, but also Correa has held on to me. He's the urologist, and he sees me, alternate 3 months. I see Gainesman, and then I see Correa, then I see Gainesman. I'm feeling like, okay, this is okay, but now I'm second guessing. Why am I still seeing Correa? He's the urologist. He did the prostatectomy. What can he do for me? But he seems to want to stay in touch with me. So is there something wrong with that? I mean, does that sound, or you think, whoa, what? Just see Gainesman?
No,
And
look,
Gainesman approved it. I mean, I talked to Gainesman about it, and he said, that's okay.
yeah, look, it's different for a couple of things here. First of all, they're both in the same institution. So there's no money involved. There's no financial issue involved. That's a big thing. And Peter did the same thing. He had a medical oncologist, but he still saw Peter Carroll for a long time. And he would stay in touch with him, and he kept in touch with him, but but they were in different institutions. I don't think there's anything wrong doing it when you're in the same institution, but I think that at some point you can phase Correa out. He's a good guy, and so is Gainesman, but they're in the same institution, and they won't be vying for different treatments.
Okay. Yep. And I mean, Correa has been helpful. I mean, he's the one who really encouraged me to retire, and he said you need to do this for your treatment. So he's done more than just the urology. So I think I'm going to stick with both of them until my PSA goes up, and then they're going to say I want to go see Gainesman all the time.
Good. Julian, what's your experience?
Well, I went through 5 urologists before I found a good one, and then he tried to pawn me off on a different medical oncologist until I went to Dr. E, which is in the same group actually, and I've been very happy since then. I still see my urologist, but it's only I'm doing okay. How are you doing? That's it. But I do have I still have my radiation oncologist I see every year.
Thomas? Thomas, you have a comment?
Yep. Yeah, okay, I've got it now. I had my microphone off. Yeah, I started off with my primary care doctor, and he sent me to the same clinic, a urologist, who I really didn't care for, right from the beginning. And he sent me to the local oncologist. So I've moved beyond the urologist, who I really have no intention of going to see anymore. He's still out there, but I don't really have much intention of going to see him. And I am now with another Vancouver oncologist who, at the advice of the group here, doesn't sound like he's really doing a good job. So I was urged to go to a second oncologist, and that's where I'm headed. I asked the urologist for the referral because I knew he could give me a referral. I did not ask the oncologist for a referral. So I asked the urologist. He gave me the referral, and I'm heading over that way now across the river over to OHSU to see what they're going to say about my condition and my treatment.
Okay, keep us informed about how you rate or what your interaction is with the oncologist there. I mean, OHSU has had some really top world-class medical oncologists over the years. They've gone through changes and so forth, but we'd like to know what your experience is with them. So keep us informed how it goes and give us names and so forth. Okay?
Yes, I certainly will do that. And
good luck.
These guys Okay, I'm done.
Okay, just keep us informed.
Wilco.
Okay. Okay, Howard Hertz.
I haven't been to this group, or maybe I came to this group a few years ago, but recently in a communication with Rick, he suggested that I bring a question to this group. And to present the question, I have to tell you a little of my background. So I was diagnosed in 2007 with a Gleason either 3.3+4 or 3+3, depending on whether you believe Hopkins or you believe, I forget the other group on the East Coast that looked at my biopsy. I had robotic surgery with Kawachi at City of Hope in 2007. I recurred in 2012. I was under the care of Peter Carroll. And Peter Carroll persuaded me, contrary to a local urologist, to not undergo salvage radiation, which was the only words out of the mouth of the local urologist. He said, just wait, see what happens. And I did wait. and my PSA slowly rose from 0.02 to 0.03 to 0.1. When it got to 0.2, I went to see Peter, and he said, you ought to talk to the radiologist, and sent me to see Albert Chang, who said, I think you ought to do 2 years hormonal therapy. And this was after a PSMA scan where they found a spot in a lymph node. He said, I think you ought to do 2 years of hormonal therapy and pelvic radiation. Peter Carroll said, wait, don't rush off into it yet. And I waited, and I went up eventually to 0.3, 0.4, 0.5. It finally got up to about 0.8, and at that point, Chang had gone to UCLA, and I saw Felix Feng at UCSF. And he recommended spot radiation to take out the lymph node. We did that, and the following year, I did another PSMA PET scan when my PSA went up a bit, and there was yet another lymph node. And Felix Feng said, I think we ought to do pelvic radiation, but we won't do the bladder and the rectum because, you're 80 years old and, we don't want to take any chance that you're going to end up with side effects that are worse than the condition. So I did that. And then what happened is while I was doing that, I was also seeing Mark Schultz in LA. And Mark Schultz said to me, do 5 or 6 months of light hormonal therapy. He called it, I think, Southern California Light, 50 milligrams of Casodex. So when I did this radiation, pelvic radiation for this one lymph node, I also did 5 months of Casodex. And then thereafter, for the next 12 months, I was really experiencing low energy, fatigue, and just really difficult. And my PSA test and my testosterone test showed by December of 2022 that my free testosterone had fallen to 3. And Schultz said, that's why you're feeling the way you're feeling. Take Androgel. I said, Androgel, what is it? He said, it's a transdermal testosterone supplementation. I said, yes, but we all know that testosterone feeds cancer. Why would I be doing that? And he explained BAT therapy to me. But it wasn't a case of BAT therapy, really, because it wasn't trying to kill the cancer by overwhelming it with testosterone. It was trying to get my free testosterone up. And I started taking Androgel. This was in December of 22. Within a month, my free testosterone went up from 3 to like 35, and I was feeling terrific. And I was on it for I guess 10 months, but still in the back of my mind, I kept thinking, am I feeding my cancer? And Schultz seemed to be fairly confident, having given the same kind of treatment to many other older men, that I wasn't in great jeopardy. And he said, if your PSA starts ticking up again, and it gets to a number where it's appropriate, we can again do the Southern California Light therapy, hormonal therapy. So now, and the reason why I contacted Rick, I'm in this situation where I'm thinking, do I want to go back on testosterone? My testosterone now is about 18, my free testosterone. My total testosterone is about 200. But I feel sort of low energy at times, fatigue. It could be aging, but it also could be my testosterone has gone from 35 and 40 down to 18 now. So when I contacted Rick, I was really interested in feedback. What would people do in my situation? Would they take that risk of maybe feeding their cancer because nobody really knows? Or if they were like me, undetectable for, I guess, almost 2 years now, would they take the chance if they really weren't feeling, the way they'd like to feel, of going back on the androgel? So that's the question. I appreciate anyone's comments and thoughts about how I might think about this differently.
Howard, interesting. You and I have kind of we've crossed paths in different ways. I mean, I had surgery with Peter Carroll. I had radiation with Albert Chang. A year later, I see Dr. Schultz, and last week, oddly enough, Mark on the phone suggested I take testosterone, and I'm weighing it. I'm thinking about it.
Hmm.
Is this something I want to get into or not? It's funny that you should bring it up. Um, I haven't made a decision yet. Um, I'm thinking I probably will wait until I do a scan and maybe do it after that. I'm not sure, but it's intriguing because Mark is he thinks out of the box. He thinks differently, and I've been with him from the get-go for 10 years now, and I trust him, um, but I'm not sure I want to go that way.
So,
That's
Peter, I
what
was going to add that my medical oncologist at UCSF, Terry Friedlander, is opposed to this. I mean, he's not strongly opposed, but it's basically not standard of care because you can imagine the legal department of UCSF if somebody took androgel and then their cancer came back, and of course there would be a lawsuit. So, but what Friedlander did say to me was this. If your testosterone's low and you're taking androgel and it gets it up to, let's say, 35, 40, that's like a normal recovery. So maybe there's no difference than if you had had a normal recovery and taking androgel. What do you think about that argument?
That's a good argument. I mean, I'm watching mine. I mean, mine plummeted from being on prednisone and withdrawing from prednisone. It just went down by itself, and then
Hmm.
it dropped like 50 points, my total. So yeah, but now it's starting to recover, and I'm just watching it. But like you, I have another medical oncologist at the University of Minnesota, Dr. Antanarakis, and when I ran this by him a number of months ago about the possibility of testosterone, he did not like that idea, and he's a big proponent of that. So I'm not sure. I'm just kind of thinking.
It's
I'm
tough,
thinking
but
about it. It's intriguing, yes.
what questions do you think we need to be asking that we're not asking?
I don't
Is there
know. I
anything
don't
that
know.
occurs to
Está
you?
bien. Okay. Okay.
Also, I should mention that I've attended a support group in Walnut Creek, California, and Dr. Weber from Seattle is a participant in that group. And I asked him the question, and he said, "No, I think I'd come down with Friedlander. I'd be very, very uncomfortable about feeding your cancer." And
So
so,
I'd like to ask the group, is there anyone else in this group who has considered supplementing? Is there anybody in this group? Please use the hands up feature if you can, which is at the bottom of the screen, and then we know who wants to respond. And if you don't, just wave your hand in the view, and Peter or I or one of us will see you. But anybody else supplemented? Anybody else considered supplementing? Anybody else run this past their docs before? Um, who's Jimmy Greenfield? Good start.
Well, hi. Interesting comments. I did not supplement with testosterone, but when my testosterone was due to be on the comeback after 18 months of ADT, I decided on the advice of a urologist I had. Was not the urologist that set me up with the surgeon. He was not the surgeon. We talked about it before. He handed me off like a baton, which that was interesting before. He didn't want anything to do with any further treatment. He sent me right over to an oncologist, and in fact said that if it was him, he would have done differently. But I'm going to send you over here to this guy. So I went to this urologist for sexual health stuff. I wanted to see what he thought about a couple of things, and I told him that testosterone was due to come back, and he said, you can take some HCG if you want, and that should help the testosterone come back sooner. I think I brought that up here maybe a time or so. And some people said, well, why rush it? Because, you might have a problem. But my attitude was, I'm either going to have a problem or I'm not. So I was willing to take this. I don't know exactly what it is, but it's something that's not a steroid, but it assists the pituitary in getting the message through to start making testosterone again. So it did come back fully in about 5 months, 6 months at the most. I don't know how much longer it would have taken or if it really did anything at all. I do know that 6 months for having been on 18 is not bad. I had such a high opinion of my ability to come back quickly. I thought I could do even better than that, but I can't claim to be been distraught about it. So I took that, and some guys take testosterone, of course, and there's a lot of argument about whether it's putting gas on a fire, and whether if it starts to be gas on a fire, you simply stop, and you can even go back on ADT, which plays right into the discussion about intermittent, obviously also. Do you stop? Do you continue for fear that your PSA might rise, or do you go ahead and take your vacation and see what happens? Well, I was certainly willing to do something that was not a steroid because I didn't want to take steroids only because I felt like if you start doing that, the law of drugs applies, and that if you take it, you're going to need it. And I did not want to get on a lifelong jag of taking exogenous testosterone, but I would have if I had not returned, I think, because I can't see any reason to not be on testosterone suppressant drugs and have the testosterone not come back and just say, that's okay with me and march on. But it's different for everybody. Anyway, that's what happened for me.
So,
Interesting.
anyone
Anybody
else? Yeah, anyone else who's supplemented or considered supplementing their testosterone and been through this this yin and yang that Howard's and Peter are running through? Or has an opinion, even if, as we say, everybody has an opinion. They're just like what. So, anybody have an opinion on supplementing?
I have an opinion on this, but as Peter started out the session saying we don't give medical advice, what I'll do is what Peter recommended we do, which is that if I were you.
Yes.
So, I mean, if I were Peter, whole different category than Howard. Peter, first of all, you're not undetectable, correct? Your PSA?
Right. I'm under 1, but I'm not undetectable.
Okay. You're a Gleason 9. So in your case, I don't think I would. That's a big risk, in my opinion. In Howard's opinion, he's what was it, Gleason 7, 3 plus 4, I think he said.
3 plus 4 or 3 plus 3, depending on the actual pathology report showed 3 plus 3 from City of Hope, but then when Peter Carroll
that's
got
good.
a hold,
That's good
Okay.
enough, Howard. Let's say
okay.
3 plus 3, 3 plus 4.
Yeah, you're low grade.
Yeah.
Right.
So in your case, and how old are you, Howard? 80?
81.
81. You're not feeling good without the testosterone. You're feeling a lot better with it. If I were you, I would take that chance. Monitor your PSA. If you see any changes, go back on the hormone therapy. Meanwhile, you're feeling like $1 million, and it could very well be that the radiation took out the 1 or 2 pelvic lymph nodes you had, and now you may never have a recurrence. You don't know. Anyway, that's my opinion.
I like your opinion.
I feel like $10 million, but I'm only 37 years old, so there's that.
Yeah. I had a guy call me up last year who lives locally on Maui, who was just diagnosed with prostate cancer, and he said, "I'm a bodybuilder. My testosterone is at 1,500, and I'm not letting that go.
Mm.
I said, okay, not much I can do for you.
Doesn't sound like natural tea to me, but who knows?
Right. I haven't talked to him since.
Is he the right side of the grass, Peter?
I don't know. I've lost contact with him. But he was
Well,
adamant.
guys, we I'm trying to give Howard, I'm trying to get as much out of these guys, but everyone's very quiet. It's not like this group. Everybody's so quiet and silent on this issue. I'm looking at some of these people. We've got 3, 4 doctors on here, and nobody wants to say anything about supplementing testosterone. Dennis, go on.
Well, I like Len's answer. It sounds very logical to me. And it tends me to believe that increasing one's testosterone, if you do not have prostate cancer, is not going to give you prostate cancer. But if you have an aggressive form of the prostate cancer, like a 8 or 9 Gleason and so forth, that's pretty risky business, I would think.
Peter, in
Okay.
your case, was your doctor suggesting something like androgel or a more substantial supplementation?
It was Mark Schultz. I don't know.
Oh,
He just
oh,
said
okay,
testosterone.
right.
We didn't get into it. I told him I'd think about it.
Did he seem rather cavalier about it?
Um, yes, in some ways he was, yes.
Yeah, that's
But
what I thought
I
also.
yeah, I think he was but I think he was responding to the fact that my testosterone at that had been plummeting. But
How
it
how
is
low
coming
did
up.
your free testosterone get?
I can't remember my free. I don't know if I've tested it recently.
So, by and large, free testosterone is 10% of the total.
Right,
That
but Mark Schultz told me, as I said to you, that it's the free testosterone that makes you feel like shit. It's not just the lower testosterone. When your free testosterone drops way down to 3 or 4 or 5, you're in bad shape.
That's where I was. I was at if it's 10%, I was down to 3 or 4. And I
Yeah,
felt terrible.
yeah.
But now it's climbing back up.
But you don't know how high it is now.
Um,
Well, what's your
it's
current testosterone, Peter?
probably about 80.
So it's probably about 8, 7,
Yeah.
8, 9, somewhere like that, Howard.
Yeah, I feel
Yeah.
better than I did a month or so ago, for sure.
Any comments, Dr. John, on testosterone, free testosterone?
And always makes good sense to me. Personally, if it was me as a Gleason 9 metastatic person, I dearly miss my tea for sure. Really miss it. But even though it would be very hard to go into the literature and prove it, I would consider it too dangerous to try.
Yeah, and John, you're a great candidate because you're not on any drugs right now. You're maintaining very low PSA, but your testosterone hasn't come back much. So you're
That's
you're in
right.
you're in that Peter you're in that Peter Kafka category.
Yeah. Well,
Yep.
maybe if we were to start an AnCan basketball team or something like that, grappling team, maybe it would give us incentive to do something like this.
Well, let me just tell you that you may need a little more testosterone because Dr. John has been talking about starting a drum circle once a month, and that takes a little energy. And Dr. John, I spoke to Jimmy about that. He's going to call you. He's got some good ideas, so
Okay,
he
I
can
always
send
like
you a
Jimmy's
personal
thoughts.
message. He can send
I,
you a
I,
personal message.
I want to get strong enough to break a drumstick, and I know I'm not right now.
Leave the
Go on,
drumstick breaking to
tell him.
me.
Do we have time? Do we have time? do we have time for Dr. John to tell the drumstick story? It's short.
Sure, go ahead.
You mean why I want to break one?
Yeah.
Because I was taking a class called Pound, where everybody gets 2 drumsticks, and you follow the teacher. It's an exercise class, supposed to be an aerobic exercise class. And you're supposed to beat your drums as hard as you beat your drumsticks as hard as you can on the floor. And this tall, really skinny female teacher broke a drumstick in half, beating it on the floor. And I was actually very jealous, and I tried as hard as I could the rest of the class. And this was before I got sick, so I was still strong to break a drumstick, and I couldn't do it. So it's always been a humiliating thing for me that I would like to get over.
John, it might have had a little crack in it, man.
Yeah?
Yours might have had a little crack in it. At least tell yourself.
Oh,
Feel better.
thanks. Yeah, maybe there was a little crack in it.
A little crack in it. That's what I
One
think.
more hit, it would have gone.
Okay.
And in all seriousness, they're not equally built. You know, the drumsticks come in many different brands, and they're made of different types of wood, and they're not a uniform strength, I'm sure.
Oh, I got a really strong one then.
Yep.
Yeah.
I
broke a chopstick at a Thai restaurant over the weekend.
Whoa, you are really strong. That's because your T is up to 80 now.
Okay. Okay, Howard, anything else you want to bring up? I put my email in the chat window to you because
Oh,
we
good.
have
Thank you.
enough stuff in common there. We should continue this conversation. I'd love to hear.
Okay.
Yeah.
Sounds
Okay.
good. Thank you.
Okay. Stu. Are you with us, Stu?
Looks like Stu might have left. I
Stu
wonder
might
if
have
he
left.
was
Okay.
he might have possibly been in the wrong group. That's a
You might have.
possibility.
Okay. You could have.
I
Okay.
hadn't seen him before.
Okay. Jack, you had something you wanted to bring up.
Yeah, so I saw my medical oncologist yesterday, and my blood tests came back. My PSA is still good, 0.014, less than. So that's a good number. And my white count has finally come back up to not what it was. It was 6,100. Now it's up to 4,400, which is so much better than 2,400. And that was the reason he cut my Nubeqa in half from 600 BID to 300 BID. So I've been on Nubeqa now for 8 months and on Orgovix for 6 months to the day yesterday. So I talked to him about whether it's inferior to take 300 BID twice a day Nubeqa rather than 600, and he said, as far as I'm concerned, he would just as soon keep me at 300 because of the vulnerability to leukopenia, white count dropping. And he said, as long as it's doing the job, my testosterone zero and my PSA is non-detectable. Let's keep it at 300. So de-escalating can be useful, he believes. And I got corroboration from Sloan Kettering at a separate consultation. So that made me feel really good because he's generally such a pessimist, from my point of view. I took your advice, Rick. I scheduled a physical therapy appointment. It's going to be next week. They didn't have anyone specifically attuned to ADT treatment. At least we don't have that down here, nobody. But they have people who work with cancer. So I'm looking forward to seeing what they have to offer as far as getting me a little more strength. I also scheduled a bone density scan, even though it's only been 8 months on the medication. He said usually does it at a year because I want to start playing golf again. I usually play 3-4 times a week. Haven't played at all since March. And I was afraid, I thought maybe I'd get a stress fracture or something like that with osteoporosis, osteopenia, whatever can happen because I'm feeling so frail. So I'm gonna, between the physical therapy and the bone density scan, I'll get a better appreciation of where I am with that. So I'm hoping I can get back to it because I really love the game. Um, um, the I spoke to him about how long I would be before I could potentially take a vacation to test. You know, I got this pulmonary involvement. At least the nodes are involved. I assume the lungs were involved at some point, but it just showed up in the nodes, and some bones are involved, even though it's small. And he said a 2 year would be minimal. There are some people. Sloan Kettering said, "Well, we can try it at 8 to 10 months." I said, "Well, let's see. I think I'm going to go with the 2 years because I want to maximize my chances of staying alive and not having further metastasis." But you know, I could see the temptation to want to get off, and because it's so many side effects. I've had some interesting side effects. I wonder if anybody else has had it. I had an explanation yesterday for where this is coming from and figure it out myself as a physician. I had severe itching on my back. It hasn't gone away, and I didn't know. I put some, steroid cream on and all that. It didn't seem to make much of a difference. He gave me an explanation, but you guys ever have a lot of itching since you've been on ADT? Let me get my camera back. Have you had itching at all?
I've had drug reaction itching for sure.
And you know
I've
what
had
was it?
itching on my back for about a year. It's not,
It,
it doesn't bother me that much, but it's itching.
it itches, yeah. So what I
You've got,
found,
hold on a minute, Jack. You've got a couple of hands up there, Peter.
good.
Okay, Dennis.
Not me, Peter. Sorry.
Dennis?
Okay, that was old hand. How about Herb Courtney? Did you have a comment on itching, Herb?
Yeah, yeah. My back's itched for quite a long time. Of course, I've been on various forms of glutamides, Casodex and Xtandi, and now Nubeqa. But I talked to my dermatologist about it, and he said, "Yeah," he said, "it's part of getting old." He said, "It's very common as you age for your skin to itch." And so he didn't really, I mean, it's not, intolerable by any stretch, but he didn't think it was a big deal and that there was much to do to treat it. So I've never thought much about it since.
He's got a back scratcher. Well, my guy said that he explained it, made a lot of sense, actually. He said what happens when you deplete the body of testosterone, which I went from 760 testosterone to 0 in 2 weeks. And he said the oil is drastically diminished. The skin, as we all recall being adolescents with pimples and all kinds of other things, we have very oily skin when we get a surge of testosterone. But as we get older, it diminishes more and more, and then we get drier skin. That if we don't keep it well moisturized, you're going to itch. And I don't use moisturizer all that much. And now I got my new idea. I'm going to stop moisturizing my back, and the rest of it, I'm hoping he's right. So that's something new. And the other side effect that I've had that I've never had in my life, I've never been constipated in my life, but I'm really constipated, and I have to, I take all the stuff and all. I just have to sit there, and eventually things happen. But God, I take psyllium husks, I take senna, I take all. And what is that? Is that the Orgovix? Is that the darolutamide? You guys have that? No?
Oh, I'm on darolutamide, no constipation problems, but I do use a lot of skin moisturizer.
What's that have to do with constipation?
I'm on, I'm still on Zytiga, and I've had constipation for the last 4.5 years since I started Zytiga.
That's reassuring. It's not just me.
Jeff Marchi, what's your experience?
Well, I actually didn't have much of a problem with Zytiga, but with darolutamide, I take Casodex and Senna, 2 of each every day, and it's sort of weird because I stopped taking Prilosec a few days ago, and I ended up having to take Miralax. It's sort of, I don't know if Prilosec gives you diarrhea, but it sort of made it much worse. And I went back on Prilosec because my stomach couldn't handle leaving it. And I still have to take 2 Senna and 2 Casodex every day in order to prevent me from having real major constipation problems.
If you
David?
want to try something, it works for me. It's an herbal from, it was suggested from the homeopathic university up in Seattle, and it's called Slow Move, and it's a tea.
Yeah.
And
Smooth
you put
move.
that
Yeah.
in there, and
Yeah.
watch out for the concentration, because if you get it too concentrated, your stomachs, your intestines are gonna go crazy on you. But you know, if it's the right amount, believe me, it works.
Smooth, slow,
Smooth
smooth,
move. Smooth
Is it
move
slow or
tea.
smooth?
Smooth move, and
smooth move.
it's in almost, well, it's definitely in any like Natural Grocer or Sprouts or Whole Foods, but I think it's also in the regular grocery stores.
Yeah.
It's not. It's an herbal, not a tea.
Right,
Yeah.
it's an
David
herbal, but you
Muslim.
take it as a tea.
Well,
David Muslim, go ahead. David?
Oh, can you hear me? Can you hear me?
Larry,
Over.
Yeah.
we can hear you now.
Okay. Um, back on the itching. I've been plagued with chronic hives, and I brought it up before, but nobody else has really had it. But it's itching is terrible. But it's. I had a doctor take a biopsy. It's chronic hives, and it's been a bear. That's the worst part about it. I asked my oncologist about it, Russell Schmulowitz. He said he's never had a patient deal with chronic hives before from the ADT.
it's Colace, not Casodex. I
Yeah.
misspoke. It's Colace. I take
Jimmy.
2 of.
Jimmy, go ahead.
Well, since we're talking about what keeps us regular, I'm gonna throw it in there. Same way that I like to promote exercise, which I always say, if it doesn't cure your problem, it does 10 other things for you. I feel the same way about something that I drink every morning, which not for everybody, but it's a combination of spinach, kale, lemon, ginger, and several other things that I put in a Vitamix, and I have it. And it's a very healthy concoction, but it also absolutely guarantees that I spread. It doesn't give me diarrhea. It just keeps me very regular. And I prefer it to any kind of laxatives or any just tea or anything like that because it's so healthy to drink. And it just sort of does both of those things for me. I
So,
do
so
want to
while
ask.
we're on this subject, I just had a colonoscopy last week, and I've met with my doc this week, and he said you got to get off of caffeine. Said no more caffeine for you. And I've never been a coffee drinker really. I just drink tea. But so I've stopped cold turkey caffeine. It's a little bit difficult, but I'm not doing it. 'Cause, but caffeine can mess with your innards too. Um, Usually not constipate you. Usually it's loose stools and get you going. Anyway, but it was interesting. I mean, he was adamant that I get off of it.
Constipation?
I'm adamant that I drink it every morning.
I know
Hey,
most people are. I felt like if I couldn't get through the day if I didn't have a morning cup of tea. But anyway, but I'm
So
trying it.
before we go
Morning.
too much
I've
before we
been
go
trying.
too much further, hold on a minute, Larry. We'll come to you momentarily. Jack, you mentioned right at the beginning that you were doing getting a referral to PT. So
Yes.
it's not so much PT that you need. It is a trainer, not a physical therapist, a trainer who is who specializes or who has a certification in cancer training. Now, the American College of Sports Medicine offers that training, and I've put in the chat window, I know you're on your phone, but it's in the chat window. I've put a link with a search tool so you can find trainers in your area who offer that. That's what you want. You don't want a physical therapist. The physical therapists are going to finish up giving you the VBEs. You know what the VBEs are, Jack?
No.
The very boring exercises.
Yeah. Well,
They're going to drive you nuts with their exercises. What you want is a trainer who is more active but understands ADT. One name that I can definitely recommend, and some of the guys in this group have found her and we've worked with her before, and she does video training, is Carol Michaels in New Jersey. And I've put her name in the chat window for you too, carolmichaelsfitness.com. And if for those of you who have trouble because you're on your phone and you can't see the chat window, we do put the chat window in the recordings. We copy them and put them straight into the recording, so you'll be able to see them there. And so those are two good suggestions for you, which I think you're going to find a lot more helpful than going to see a physical therapist.
All right, that's good. I'll give that a shot. I'll try a couple of physical therapy sessions, get some balance, and whatever else they're going to do. And if it turns out to be boring and worthless, I'll quit. That's all, you know. But I'll take that name down and I'll check it out. Thank you.
Okay, and the ACSM search tool may identify a trainer with that certification in South Florida.
Okay.
I'm sure you got a bunch down there.
I'm sure. Thank you.
Okay, Jack, we're going to move on because this is
Let me just say
an endless subject.
One thing. I want to thank Jimmy Greenfield. The other night, Rick put me on to the interview that he had with you, where you put out 9 songs or so. And last Monday, I fell asleep and had a great night's sleep listening to you. And I want to thank you for just wonderful entertainment. It was such a pleasant surprise. Your talent is overwhelming. It's beautiful. I wish my mother were alive. I would have loved to have shared it with her. She passed 10 years ago at the age of 101. But your work is magnificent. So thank you. If you're still on, you're still there, Jimmy.
Good. Yep, he is. Okay. Larry Fish, I know you got cut off. Do you have something important you have to say? Because we've got some other people we've got to get to. No? Okay. Herb Courtney. Said you had something you wanted to...
Oh, well, I just wanted to give you a little update. I had my latest blood work just about a month ago and then saw my GU Med-Onc, Dr. Rettig at UCLA about a week after that. And I had my last Lupron 90-day shot the end of April. And then when it came due 3 months later, we had decided it probably wasn't necessary to stay on it because in early May, I had started on darolutamide. And that combination just nosedived my PSA, and it ended up at about 0.05. So we just left me on the darolutamide, and my latest blood work showed a PSA of 0.03, which doesn't sound like a lot, but it's a 40% drop if you look at it that way. But the other interesting thing is previous to this last blood work, my testosterone total had been less than 6. So basically undetectable with that kind of test, whatever it was. This last blood work, my total testosterone was up to 193 at the same time that my PSA went from 0.05 down to 0.03. So I thought, boy, that's the best of all worlds. One other thing is during the time that my testosterone was less than 6, which was quite a long time, thankfully I didn't have any fatigue or side effects other than a penis that was shriveled, and I was working out 3 times a week in the gym. So take that again. It's just apparently such a individual disease. So Reddick and I are just keeping on the same path. I'm just going to stay on the darolutamide, no Lupron, and keep watching things. And if it stays where it is or even keeps going lower, we just stay the course.
Good for you. Great news. I'm sure you feel really good about. Are you taking the full dose of darolutamide? Huh. Good.
That sounds good.
How do you feel? I mean, taking with your PSA, with your testosterone back up, how are you feeling? Whilst also taking the androgen receptor blocker, Herb?
I don't really, I couldn't tell any difference. I mean, I didn't feel like, oh, maybe my testosterone's up, I feel better. Or like I said, I really didn't have any adverse effects when it was less than 6. So I can't really tell much difference. Of course, 193 is still a ways short of, I think my normal was up around 500 to 700. But like I say, the only downside is, of course, total ED. But hey, I'm 86, so not a big deal.
You're doing great for 86.
Herb, I don't know. I don't know that Dr. Jack would agree with you. I mean, we gotta talk to our contemporaries here. He may not agree that it's such a big deal to have ED at 86, but I think he's only 85. How old are you, Jack? You're muted. Tell us, how old are you? 84, 85, 86?
84. I was 84.
84. At 84, it's a big deal, but when you get to 86, it won't be a big deal.
Okay. Well, right now I get no erections at all, and before I started this stuff, I was still okay because I had a lot of arterial perfusion with Trimex and all the other stuff, so I worked on it from the get-go. But believe me, I was gonna maybe at another group we'll talk a little more about how one lives without some orgasmic delights in life for so long. I guess you get to the point where you just don't miss it anymore.
You're in good company.
Yeah.
Yep. Believe me.
Yeah.
I think we took a poll. I think that you have a lot of colleagues in this call. Anyway, thanks very much, Herb. It's
okay.
Excellent. Keep it up. That's really good news.
Yeah.
Okay. Lynn, I know you wanted to wait till the end, but we have.
Yeah, 4 minutes.
We have, huh?
Oh, you have somebody else?
Well, we do, but I want to make sure. I want you go first because the ones came in very late, and one's a new person. So we'll go ahead with your story first before we go.
Okay,
to
this should be quick because I just wanted to get maybe a show of hands here. I was got a bit of a sticker price shock when my bill came in for the PSMA PET scan I had in October, which was about $9,700. My copay was over $700, and I have good insurance. But what surprised me was that half of that 9,700 was just for the CT portion of the PSMA PET scan, which I had no idea a CT scan cost over, I think it was like $5,700. So just curious, anybody recall how much they paid or how much they were billed for the PSMA PET scan? I know Peter told me you were billed $36,000. I'm sure you didn't pay anywhere near that, but is that right?
That's what the hospital asked for, but that's not what Medicare paid. I mean,
Yeah, right.
Yeah, I wasn't billed that, but that's what
I just had, Len, I just had a PSMA scan here in Tucson. And of course, it was done at the Arizona Oncology Radiology. And actually, the business person called me and made sure that my insurance would cover it because it was $3,500. That was the price tag for me.
Well, that's what I thought these things cost. So I
Well,
was surprised. Anybody else?
I've had 4 of them. I think 3 at UCLA and 1 at a private outfit in Oxnard. And I think they were all in the neighborhood of, like you said, around $9,000-$10,000. Fortunately, I haven't paid a dime for any of them. But yeah, your price of 9 just doesn't. I can't remember exactly. I'd have to go back and look on my records, but doesn't sound, terribly out of the average.
Thomas, what's your experience?
Well, I had my PSMA PET scan at Legacy Hospital in Salmon Creek, Washington, just north of Vancouver, Washington. Oh, when was it? I don't know, several months ago, 3 months ago, or something like that. And the summary, the Medicare summary, I got in the mail. The first number there, the number that, and I'm not an expert on these billing numbers. It's just what I remember seeing was around $13,000. That was the first number until they took out what was approved by Medicare and how much was paid and how much I might be paid and all that. But that first number was 13,000. And if that's the number that they're charging, that sounds a lot more than, $9,700.
Well, they're all over the map, obviously. I mean, depends on where you go, and yeah.
Jack, didn't you recently have a PSMA PET? You muted.
Yeah, I've had a whole bunch of them. I've had, but I fortunately have Medicare. And in the beginning, before I even had a C11 choline scan back in 5 years ago. So I had 2 PSMAs, 1 Aximum, 1 C11 choline scan. All of them were paid for by Medicare. One advantage of being older. Len, I don't know how old you are. You're a young man. So
No. I'm on Medicare, but Medicare, like Peter's case, they only paid 6,000 of his 36,000, and they paid about that much out of my 9,000 too.
Wow. Yeah, I remember they billed me around. They billed Medicare around 13,000. That was about it, 13.5, something like that. And the Aximum may have been a little less. The seal choline, I don't remember. That was a whole Mayo thing. But I'm just
trying to. Yeah. I don't think any of us are going to figure out hospital billing and Medicare. And all. I mean, it's just all over the map. So
yeah,
who knows?
I mean, I don't think you should pay a lot of attention to that top number that comes in, to be honest, because it's a number they sort of literally pick out of the air. Um, and and nobody pays that first number anyway. Even if you go in and you pay cash and you don't have insurance, it's a completely different number.
Right.
It's not the number that's approved by Medicare. Who knows what that number is? But it's a fantasy. My experience has been it's a fantasy number. I mean, I remember when I got my IMRT at UCSF, they actually sent me the bills. I didn't pay anything because I was on it was covered by Kaiser. But I mean, I think that my IMRT treatments were in the hundreds of thousands, 300,000 or 400,000. I mean, it was ridiculous. It was ridiculous, but it doesn't mean much. Before I think Peter wants to go to Dr. Carlos and the new gent for whatever time we have left, which is maximum half an hour. But I just want to say that if any of you can recommend a really good web uh, WordPress designer, and also somebody who has good information on also the other part of the back side of the site, which is the host, etc. And they have a resume to support that. Please send their names to Alexa at AnCan.org. We are currently looking around. We've basically determined this week that our website designer probably is no longer appropriate for us. We've been having a lot of issues. I don't know. I have to check with Frank and see if you can make a donation. You couldn't at the beginning of the meeting. I don't know if you can now. But we've been having a lot of problems. So we're scouting around, but we want somebody. I know Neil Sundstrom kindly sent us one name, and some of you have given us names, and Alexa's following up. And but somebody who is really solid and they do good work. And we may split those two functions up. So just saying that, and also for the recording, people who pick it up on the recording.
Okay, very good. Okay, so I got about, well, it's about quarter of. So Carlos, first, you know, I got to remind you, you know the game. Here, try to get here at the beginning of the meeting, you know, within the first 10 minutes. So, because fortunately, you struck it rich tonight. We don't have a huge crowd, and we don't have a lot of new people, but I'll just introduce you quickly. So Dr. Carlos Huerta, he's been on. Most of you know Carlos from Tucson, and I don't know what your connection is, but there's a gentleman also named Mike Morris who's on as well, and Mike lives in Indianapolis, I believe, and Carlos mentioned that he's well, I'll let Carlos introduce the thing quickly of what Mike's issue is and what's going on, and we'll figure out what kind of questions we need to ask. So go ahead, Carlos.
Thank you. And just to backtrack just a moment, just to reiterate what Rick was talking about, these bills, they can charge whatever they want. They change their billing every year because hospitals can do that. But it's what they contract that's going to get paid. And that's a whole new ballgame where you mention one number and it's a tenth of it, and then what is actually payable and what your copay is depends on your health plan. And if you're Medicare, you know, it's 80-20, and you have a way to pay the 20% through a Medigap plan. And that's where you end up with what you end up. So I don't know if that helps you, Len. As far as the new person, it's a personal friend of mine, Mike Morris, who gave me a call that he was recently diagnosed. And so I asked to gather some information, get his PET scan complete. And at that point, it would be a good time to reach out to the group to find out what the recommendations are in terms of what he ought to be thinking about going forward.
So Mike, you were diagnosed pretty recently, yes? Like August
Yes,
or?
I was diagnosed at the end of September.
Okay, so very recent, hot off the press. And
Yeah.
what was your diagnosis at that time?
I mean, I had my PSA was 60,
Okay.
and then had the biopsy done. There were 8 cores. 2 were at an 8, a Gleason of 8. 1 was at 7.
Okay, so
And then I
Gleason
had the
8.
PSMA. I had the PSMA test done, which I paid $170 for, by the way. So, and at this point, have interviewed with a radiation therapist, and I had my first Firmagon shots about 3 weeks ago tomorrow. And I'm due to go back on the 18th for my next shot.
So it's a Gleason 4 plus 4, 8, correct?
Yes.
Not a 5, 3. Okay. And where are you being treated? Are you going to a local clinic, or are you at a university? What are you doing?
Well, right now I'm in a urology practice.
Okay. And you're in Indianapolis.
Correct.
And they were able to do the PSMA scan there, and you didn't have to travel any place.
Correct.
Okay. And do you have a medical oncologist, or are you just working with a urologist at this point?
Right now, just the urologist. I'm working on the oncologist. I just haven't, it's hard to track these folks down because I don't really know. I mean, I've had a couple of recommendations, but in talking to Carlos, fairly extensively, his indication is that right now the urologist is saying radiation is my avenue. Surgery is not an avenue at this point. So the recommendation has been to pursue proton treatment, which I'm kind of in the throes of doing. Yeah.
They do proton there in Indianapolis? They have a
No, I'd be going to Houston.
So who is recommending proton radiation to you? Who recommended the proton radiation?
Can you hear us, Mike?
I have just heard that, but no, I mean, okay, go ahead, try again.
Who recommended proton beam radiation to you?
Well, it was a discussion I had with Carlos, and then what I did is I have a friend who's on staff at Johns Hopkins, and I asked her, and she asked her colleagues, and her colleagues indicated that a little less treatment and far fewer side effects.
Okay.
So is this proton SBRT, or is this proton? How many treatments are they doing to the gland?
Whoa, are you in good
I don't know yet.
Yeah.
I haven't met anybody about it. I haven't talked to anybody about that. I'm still
Well, I'm
waiting
glad to hear
for
from you, Fran.
a couple of things on Medicare to try to get into MD Anderson down in Houston.
Okay, so to cut to the quick, because we don't have a lot of time. There's no proton beam is no magic bullet. It's really, there's no evidence that it's any better than photon. It can be provided through SBRT, stereotactic body radiation therapy, in which case you can do part of the treatment in concentrated fractions. But today, I would see no reason to do all the treatment in small fractions, both for the gland and across the pelvic girdle, number one. Number two, to travel to MD Anderson for PBRT, I think I certainly wouldn't do it. I wouldn't do it. Now we've had men, and you can go to Peter's group where they often talk about photon versus proton. But our view here is to make it efficient and quick, and probably the best way to do that is either SBRT to the gland plus pelvic girdle radiation. Dr. Roach at UCSF is doing 2 treatments to the gland and about 20 treatments across the pelvic girdle. So you can do this in 22 treatments. He's not doing it with proton. Proton may have less side effects in the GU area. It may have more side effects in the intestines, and the reverse for photon. But there is no magic bullet, and we try to keep everything very, very balanced here. Mike.
Mike, did you get the results?
Not just yet, Jerry. Hold off. So let's just get the moderators done, and then we'll open it up to it. We'll open it up to everybody.
Mike, did you get the results from the PSMA scan?
Yes.
And what did they show?
Prostate and 2 lymph nodes.
Okay. And you say they ruled out surgery. Why did they rule out surgery for you? Age or what?
I just turned 65, so I didn't get an answer to that question of why. So that's a question I would have to ask.
They must have figured that curative surgery was impossible.
I'm sorry, say again?
They must have figured that curative surgery was impossible since your disease has gotten out into the lymph nodes. You know, when they take your prostate out, they take a bunch of lymph nodes, but whether they happen to get the right ones, you don't know.
Yeah, but John, they debulk now, and got Carl Foreman, God rest his soul, went through that trial where they even though he had metastatic disease at diagnosis, they still gave him surgery. So if they're going to debulk,
it would be worth it just for the debulking, you think?
Yeah, I mean, so look, there may be other reasons, but if they're telling you it's because it's metastatic, that's not a good reason. I mean, if they have other reasons that they're not doing surgery, that's fine. You may not want to do surgery either. You may prefer to do radiation, and you have a choice. But what we do know is the gland needs to be treated, and the whole pelvic girdle needs to be treated. And there are a whole number of ways to do that. It's interesting. Recently, this week, I've been seeing people being pushed towards MD Anderson. I don't know what the magic is about MD Anderson anymore. There was a time when there was magic to it. But, you have a good comprehensive cancer center in Indianapolis. And I would start by seeing somebody there, since you have metastatic disease and some evidence in the lymph nodes, where we can try and see if there's a GU medical oncologist there, and they can guide you either to a urologist or a radiation oncologist there. And if you're not happy with that, then by all means go down to MD Anderson or somewhere, Chicago, or
No, I have family in Houston, so it's easy for me to go to Houston.
Okay, so so by all means MD Anderson, but it's not. I would say that you're not necessarily going to get any bit better treatment there than you might do at a good NCCN hospital anywhere else.
Okay.
But if it was me, I mean, you're still new into this thing. I would get another opinion. I would get, several opinions from, top-notch urologists and medical oncologists, and because there's multiple ways to go with this. This doesn't have to be done tomorrow. This is not runaway disease for you. Even though your PSA is up at 60, it's not This is not the end of the world. And you say they've already started you on androgen deprivation?
Yeah, Firmagon was the first two.
Firmagon. Yeah, I would try. As Rick said, make an appointment with the university there in Indianapolis, um, and or make an appointment with someone in MD Anderson, um, and just get some input. The Firmagon is going to bring your PSA way down, and it'll be under control, and you don't. This is not going to run away on you, and you'll have time to kind of research this and make the whatever decision you're going to land on will be the right one. But you're in that place where it's going to be crazy making, because some people are going to say radiation, some people are going to say this kind of radiation, some people are going to say that kind of radiation, some people are going to say surgery, and you're going to go back and forth and lose sleep at night. But eventually you will land on something that feels right to you, and a doctor that feels right to you, and a facility that feels right to you, and it will work. Okay? And this is not you're not gonna die of this, at least anytime
I'm too busy
soon.
to die.
Okay? You'll be okay. I mean, a lot of us have been around a long time dealing with the same things. I've been around for 9 years, or some 15, 20 years on this call, who've got pretty serious disease, and we've managed it. So, Herb, do you want to make a comment?
Yeah. When I was first diagnosed, one of the alternatives or one of the treatment modes that I considered was proton radiation. And I had a consultation down at Loma Linda University, which of course pioneered the proton radiation. And I had a Gleason of either 3.4 or 4.3, I can't remember which. And anyway, they looked at that and said, well, we wouldn't consider proton radiation to start because of my Gleason score. And like I say, it was only 7. And as I recall, this gentleman's was above that. So they said they would do conventional radiation followed by proton. And I didn't go that way, but I just throwing that out.
Somebody else had their hand up.
Carlos.
Carlos, Herb, out of curiosity, what did you do?
Oh, I opted for robotic surgery, and then a year and a half later, I fell into the approximately 30% recurrence after surgery.
Right.
And I had
Jerry Pelfrey also had a comment, Peter, as well as Carlos.
Yeah, I lost my thought trying to get the rest of Herb's story there, but I'll think about it and raise my hand again.
Okay, go ahead, Jerry. Jerry, you're muted.
Yep. I know Rick doesn't agree, but just let me give you my history. I'm not going to comment.
Don't do the whole history. Just cut it short.
We don't have time, Jerry. What is your point?
I'm not going to. All right. I was totally metastatic. I was at Mayo in Phoenix. I took proton because it wouldn't penetrate the rest of my body. And I had that 4 years ago. And I haven't had anything, no side effects from proton. And I had an SBRT with photon, and by God damn it, I got a side effect that I have to live with for the rest of my life. That's it. That's my point.
Where was the SBRT with the photon?
Mayo.
What did they radiate?
L4, 3 and 5.
Okay, that's a whole different ball game.
Well,
And
that
this is
may
the
be
this
fine.
is the problem, that we're not talking about radiating metastasis. We
No, we
can't
were talking
compare.
about the
We
proton bed
can't
and the.
compare radiating metastasis with radiating the gland and the pelvic girdle. What you're saying is the radiation to the pelvic girdle and the gland with photon over 40 or 45 treatments for you was very successful and you didn't have any side effects from it. Is
It
that
was
correct?
20 treatments, and
It was 20 treatments, but did they radiate the gland or did they just radiate the pelvic girdle?
They radiated the gland and the gland bed.
Right. So again, we strongly believe that that is insufficient for metastatic disease. We believe that you need the pelvic girdle radiated. It should be something you discuss at length with your radiation oncologist. That would not have been standard of care. Now, they may have done that in your case because they were debulking and because they were also putting you on extensive other treatment because you had metastatic disease. That might have been their reasoning. Could have been. So basically, what they did for you was to debulk the gland and to treat the prostate girdle in a different way.
Okay, but I didn't have a problem with PSA until 2.5 years later.
Okay.
Fine, because
Well,
you didn't have a problem because you were on hormone therapy. You know, we're going down a rabbit hole here, which
Yeah, you
is
are.
not what we're talking about. I have no problem with photon beam. I have no
we're getting
problem. All I'm
getting off
saying
track
is
here.
photon beam, this is on track. Photon beam is no better than proton beam. It's that they're even up. And in and in the case of Jerry Pelfrey, he had photon beam to the gland only. That's not the situation that Mike Morris is faced with. It's not the situation that a lot of guys are faced with. But in Jerry's case, where they only radiated the gland, he had no side effects from those 20 sessions. Those 20 sessions can now be done in 4 or 5 sessions, either with photon or with proton.
Okay.
Right now, the interview that I had with the radiation therapist here was 6 weeks, 5 days a week.
Right. Yeah, that's IMRT. That's standard. I would, again, if it was me, I would start either at MD Anderson if you've got family there and it's easy for you. Make some appointments to get second and third opinions. Talk to top urologists, talk to top radiation oncologists, talk to some medical oncologists, just to gather the information and explore your options. Carlos, you had something you wanted to, did you remember?
Yes, for the benefit of Mike and the general group, is there a consensus, so to speak, as to what kind of timeline he should look at? Should he say, let's figure 2 months to get all the groundwork done and make a decision, 3 months, 4 months? What is there a group consensus or recommendation?
Oh,
he's on Firmagon. So once you're on the Firmagon, you're basically holding the disease as long as you're responding. When was your first Firmagon shot, Mike?
3 weeks ago tomorrow.
And what's your PSA now?
It hasn't been taken.
Okay, well they should try and take it at least no later than next week because we want to know that it's working.
Right. Yeah.
Right? The other thing is that we would say to you, don't get an Orgovic. Get onto the pill, the Orgovix pill, rather than the Firmagon. It's the very, very similar drug, but your recovery from it is going to be much, much quicker. So when you go in for the second one, see if they'll switch you to Orgovix. It's probably a better medication than the Firmagon. In terms of how long after that, since you've already started, you're probably going to have to be on it 6 weeks to 8 weeks before they want to start any radiation anyway. So you have time. But if it's a little bit longer, I think that's okay as long as you're on the phone. We can't give you medical advice, but I think a doctor would say once you're on the hormone therapy and it's driven your testosterone down, you have time to make the right decision. One thing I will say to you is that you don't need to do 6 weeks. You can do high dose brachytherapy, low dose brachytherapy, SBRT, and that will take at least 20 sessions out of that. Now, if you don't mind going in every day, the difference that they're pretty much equal. We don't think. In your case, actually, we do think. In your case, what we think is the best and what the trials say are the best right now is high-dose brachytherapy plus radiation to the pelvic girdle plus ADT. SBRT might be equivalent to that, meaning instead of the high-dose brachytherapy, 3 or 4 sessions or 2 sessions if you do it in some places. But we don't have that trial evidence yet. But it seems like you could do, and it's so easy. You could do 2 SBRT and then the treatment to the pelvic girdle. The 2 SBRT and the treatment to the pelvic girdle is the protocol that Dr. Roach is currently using and some others at UCSF and getting equivalent results. And so, that would cut you back to maybe 22 sessions. So it's significant and should be discussed. And be careful, because doctors will tell you they can't do it because they don't have the equipment and steer you somewhere else. But the question is, what's best for you? And then you decide who's the best doctor to do that treatment for you, not who's the best doctor subject to the equipment they have at their disposal.
So addressing Carlos's comment, Carlos, what do I say? In terms of timing, I was in your situation, Mike. I started hormone treatment, ADT, right off the bat after my diagnosis. And it took me 8 months. It bought me 8 months. And I was in Gleason 9 up with pretty aggressive disease. I went up and down the West Coast trying to figure out, interviewing doctors, trying to figure out what my treatment strategy was. And I ended up landing on, in my situation, surgery because of the circumstances I was in. But I had 8 months to decide. I wasn't in a panic. I just went up and down the coast talking to different doctors in Southern California, Northern California, etc. So, this is not something you have to decide tomorrow. Just take your time, talk to doctors. A lot of the terminology of different kinds of radiation probably have kind of gone in one ear and out the other ear. So you got to sit down and research. Carlos can explain some of these radiation things to you, but just take your time. Don't panic. Don't feel like this is runaway disease. You're under treatment already. You've got time. Anybody else?
Yeah, just to follow up on the recommendation for the Orgovix. The cost for that out of pocket when you're on Medicare with a supplement, can anybody give us some information?
The cost for what now, Carlos?
The Orgovix when you're on
going
on the supplement.
Some guy, well, yes. I mean, there are guys in here who have gotten it covered. There are guys in here who are paying a difference. Who's on Orgovix and what are you paying, guys?
I don't think anybody's on it right now here who's left.
Anyone in this group on Orgovix right now? All right. Anybody on the group been on Orgovix, and what have they paid?
I paid nothing.
I ran like, prescription Part D of Medicare just to see what it would be, and I think it was like, I want to say it was like $1,700 a year, somewhere like that. It wasn't a lot.
Yeah, I mean, again, if
Thank you. I
you've
just
got a
wanted to get some perspective on that.
yeah, it's something you've got to work out with a good GU medical oncologist, or sometimes a good urologist, but probably not. I mean, it's beyond the urologist. The good GU medoncs know how to get it, and in the cheapest way. And Carlos, you know that. You know how some can do it, some can't do it. You've had that with your medications. And and again, it also depends on your insurance. If you've got a good Part D plan, you may be able to get it. It just varies. What we can tell you is it is an equally effective drug with lower side effects, and your testosterone is likely to recover quicker.
Right.
Okay, Mike, keep in touch with us. Let us know how we can help you. And do we have your email? Or Carlos can give it to us. Mine is peterk@ancan.org if you want to send me an email.
Right. I mean,
I'll keep in touch with you. peterk@ancan.org, ancan.org. Okay.
And if you want to sign up, and Carlos will show you how. Sign up. You'll get the reminder every week. You're very welcome to come back on. It's really unusual that we'll take a new guy so late in the meeting, but you were very lucky today that we had extra time.
Well, we had technical difficulties.
Technical difficulties. Okay.
Yes, indeed. Yeah, I had to move my computer just to get on. So yeah.
Okay.
I'm sorry. Jay Newman had questions about the Ember device. We're going to have to defer it till next Monday, but we will definitely take those questions on the Ember device next Monday, Jay. But you got to speak up and ask for time, and then the guys will all say, will tell you about their experiences and hold up their wrists. I don't know. Anybody wearing an Ember right now who's left?
Most guys have left already.
Yeah, a lot of guys are left, but we're happy to talk to you about it next week.
Okay, great, thanks.
Excuse me, Peter. Anyway, I have a question for Mike. Are you a veteran?
No, I'm not.
Oh, okay. I thank you very much.
Okay. But you are on Medicare. You are 65?
Yes.
Good. Okay.
And I just made the switch from Advantage plan over to a G plan.
Good. Way to
Amen,
go.
Okay.
brother.
That's a very smart switch, and that will cover you. What do they call it? The Simon Center? Isn't that the name of the new Indianapolis Cancer Center there, the NCCN one? And
It's probably attached to IU, isn't it?
yeah, and and so that's the place. It'll cover you. It should cover you at MD Anderson, but MD Anderson can be quirky. MD Anderson can be very, very quirky. They don't take Medicare from out of state people.
Right.
So
well, if that's the case, then in terms of what I've heard tonight, okay, there is an MD Anderson here in Indy. Okay.
yes, it's not the same. It's
Yeah,
branded.
I kind of figured it wasn't.
Well, it's kind of like having a McDonald's franchise. So it's the same with City of Hope, same with Mayo. Well, no, not the same with Mayo. Mayo's different, but certainly with MD Anderson. Now, it doesn't mean to say there aren't good doctors at the local MD Anderson, but MD Anderson, Texas, Houston, it's very hard to get treated on Medicare, but we do have guys who do go there. So again, come back in, ask them whether they've accepted their Medicare. But we are aware of situations where they haven't accepted. And by the way, if there's any, well, Carlos, this is interesting for you. We found out where Alan Bryce went. He went to City of Hope in Phoenix. Did you know that?
Yeah, I knew that. I don't know if I told Peter or somebody, but yeah, we dug him down, and I need to reconnect with him for future consultations.
Yeah, I mean, I know you saw him for a long time. I know you may not be as high on him, but we think he's a very, very good doc. And especially in Arizona, where we don't have a lot of good GU med oncs, we're so pleased that he's stayed in the area. And they gave him a better opportunity than at Mayo Phoenix. And so he's the head of clinical something or the other there. And I don't know what, but yes, but so we know that. Okay.
Good
Well, I
night.
appreciate you letting me in.
Okay. Good to meet
Come
you.
back in. Come back in. You're welcome to come back in. The next month meeting will be next Monday. And Len's running that next Monday.
Okay. Okay, guys. Good night.
Take care. Thanks, guys.
Yeah. Okay. Good
I'll
night.
get you my reminder early this week, Rick.
Thank you, Len.
Okay.
Good night, Peter. Good night, Carlos. Bye-bye.